Good evening, everyone. On behalf of Intas Pharmaceutical Limited and Janet Division, I, Dr. Mithilesh Nayak, welcome you all to this 15th episode of Endocrine Talk Show. And today we have interesting talk on goiter. So our panel of experts will going to dissect various aspects in management of goiter, including the pathophysiological aspect from investigation, from medical management to surgery. All these various points will be discussed during the sessions. And to moderate today's session, we are having with us our course director, Dr. Subhankar Chaudhary, sir. He is a professor here at Department of Endocrinology, SSKM Hospital, Kolkata. So with this word, I hand over the digital podium to Dr. Chaudhary, sir, and request him to introduce our panelists for today's program. Over to you, sir.
Thank you very much. Very good evening to all our audience across the country. This is another episode, and once again, we have brought in a topic which is of general interest, condition that you all see, goiter. And as on earlier occasions, we have excellent panelists. And this time, because it's goiter, we have got not only endocrinologists in our fold, we also have a pathologist and a surgeon to help us navigate our issues. And amongst the panelists, we have none other than Dr. Anil Vansali, who headed the Department of Endocrinology at PGI in Chandigarh, currently Director Genie Health in Mohali. And he's got vast experience, has published widely, more than 500 publications. He has been a BC Roy awardee and a former president of the Endocrine Society of India. We also have this evening, can we go on to the next slide? And we have another endocrinologist, very eminent endocrinologist, director and consultant, Gandhi Hospital in Nagpur, Dr. Pramod Gandhi, who has been on the Executive Committee of Endocrine Society of India, has been a founder secretary of Maha Endocrine Society. So welcome, Dr. Pramod Gandhi. We have in our midst today, Dr. Jyoti Chaudhary, who will look after the pathology of the issues related to goiter. She heads the Department of Pathology at the Institute of Child Health in Kolkata. She's also president of the Calcutta Association of Practicing Pathologists. And she has a vast experience under her belt. We are very happy and fortunate to have with us Professor Abhimanyu Basu, who heads the Department of General Surgery in the institute that I work in, IPGMER and SSKM Hospital, Kolkata. Again, he is a very renowned and experienced surgeon and a wonderful teacher. So, a warm welcome to all. So, goiter, as we all know, is something that all of us do see. Now, if you happen to be an autopsy surgeon, you may be seeing it in 60% of whoever come under the knife. If you happen to be an ultrasonologist, you may find a goiter in at least 30% of your patients. If you are a clinician, as we all are, maybe we see it in at least, around 5% of our patients. So it is indeed a common condition, and we are also seeing increasing numbers of goiters and thyroid-related problems. Now, as we await Dr. Bansali to join us, let me once again request all of you, the audience, to put in your questions in the chat box. Your questions will have precedence, so whenever possible, we will try and answer as many of your questions as possible. If your question has not been answered, it's definitely either because we ran out of time or maybe because it was already answered during our course of discussion. So, very warm welcome to Dr. Anil Bansali. Good to see you.
Thank you.
So,
Thank you, Shivankar.
so we were talking about goiter, and a general comment that we all hear, just as we say that diabetes is increasing in our country, so also it appears that thyroid disorders are also increasing. Do you think that there's a real increase, or it's just more detection because awareness has increased?
Yes. So I think, Shubhankar, what we used to know in our clinical setup is that the diabetes is the most common endocrine disorder. And for thyroid disorders are the second most common endocrine disorder of following diabetes. And if you look for that, the hypothyroidism being the most common in that, followed by the goiter, and followed by the thyrotoxicosis. And lastly, because we don't have much data about the thyroid malignancy, so that will be the least, but still, because being a referral center, we used to see a lot of patients. But the most common disorder being the hypothyroidism, and followed by the goiter, and followed by maybe multinodal goiter, and followed by the thyrotoxicosis. And you rightly pointed out whether like a diabetes, whether it is an increasing awareness which has led to this, or whether it is really a truly increase in that. So I think partly yes, definitely awareness and availability of the thyroid hormone assays at most of the places in the country. Even you go at a small district headquarters now, you have a thyroid hormone estimation facilities. So that's a one awareness. Beside that, the overall goiter would have come down because of the iodine repletion program and use of iodized salt globally. But even after that, use of iodized salt, there is a definitely increase in both hypothyroidism or Hashimoto or autoimmune thyroiditis, as well as the thyrotoxicosis. Both have in fact risen up. So this may be related to overuse of the consumption of the iodized salt. That may be the one reason, because the data from our own country, from Delhi, they showed even this. They showed that there is an increase in a Hashimoto's thyroiditis with the use of following iodine. So there is. So I think the both the factors are contributory. One is awareness. Secondly, availability of the TSH assays, and thirdly, the overall use of iodized salts. And lastly, I think not much work have been done on that area, that is in endocrine disruptors, contributing to more thyroid dysfunction. That may also be one of the reasons for that. But certainly, it still remains the second most endocrine disorder following diabetes.
Right. So, Dr. Bansali, but iodization of salt and program was essentially to reduce the prevalence of goiter. So now you say that this has led to increased goiter. So is that unique to our country, or has it been shown in other countries? Because
Yes,
it's not just India who's got the iodization program.
yeah. So I think that has also been shown even in the Western world, that you have got a more thyroid disorders following iodine supplementation programs. And the reason for that, when you are exposed to iodine for a long time and possibly in excess quantities, then you have a more leakage of antigens from the thyroid follicular cell. So Dr. Marwa, in fact, showed his study from Delhi, and this was in a school children. I showed that there was an increase in prevalence of antibody positivity as well as the goiter, and some people even have contributed, even have attributed to micronutrients, particularly iron deficiency. People have also talked even in India. Even people have talked about also protein deficiency and selenium deficiency. So micronutrient deficiency, iron, selenium, and even macronutrient as a protein, and possibly the I don't say over supplementation, but certainly as a salt, we people consume much more than the what our counterparts in the Western population. So we consume salt in so many ways, in fact. So that will be the one of the reason that we might, because urinary iodine excretion studies are hardly done. So if we really do that, possibly we might be consuming more iodized salt, and that will lead to more leakage of antigens and induction of autoimmunity, which may
Okay.
contribute to this.
Right. Yeah. So on that note, understanding that iodization program may be a double-edged sword as well, let us turn to the issue of goiter itself. And Dr. Gandhi, for the practicing clinician, a person comes with goiter. So, what is the minimum quick history and what is the quick clinical examination that you would suggest is essential?
Yeah, thank you, sir.
And remember, this is not uh, a sort of not so busy endocrinologist who is looking at the patient. It's a very busy clinician.
Physician. Yeah. As sir has rightly said that the goiter prevalence is very, very high, probably second commonest disorder which we see in our OPD practice, especially in endocrine OPDs. But then when you talk about physicians, they do see a lot of such patients. And in such cases, the simple questions, the duration of onset of goiter, these rate of change at which it is increasing in size, whether it is rapidly increasing, whether it is constant in the size, whether it is nodular, single nodule, multinodular. Can patient identify whether it is a single nodule or multiple nodule? That's very important history. Whether patient has any pain or tenderness over the thyroid gland, that is also important. Sometimes if goiter is very large, which is sometimes our patients do present very late in Indian scenario, where we see large goiter, we can ask even the history which is suggestive of various compressive symptoms of large goiter, like hoarseness of voice, change of voice, breathlessness. Even in malignancy, we do see hoarseness of voice or breathlessness, which is very common in large goiters. Then probably patient, we should ask history of certain goitrogens which patient is taking, or certain drugs which patient is taking, like lithium or antidepressants like lithium, tyrosine kinase inhibitors, phenobarb. These drugs can also sometimes cause goiter. So long-standing drug intake history is also important in these patients. Then history which is suggestive of various thyroid symptoms, hypothyroidism or hyperthyroidism. That's very important. In children, it's very important to ask the history of growth. Is there any recent sudden recent decrease in the rate of height velocity, sudden short onset of shortness, short stature? That's very important history which gives us the clue towards the hypothyroidism. Even in children or even in girls, pseudo precocious puberty, like patient can have only premature thalarchy. These are the various symptoms which are suggestive of hypothyroidism. Other common symptoms are hypothyroidism, obviously dryness of skin, lethargy, scholastic recent deterioration in the scholastic performance. These are very common symptoms of hypothyroidism. And about hyperthyroidism, history of sudden onset weight loss with increased appetite, tremors, palpitations, exophthalmos. All these signs we can, all this history we can ask it to our patient. So that probably gives us the clue whether we are dealing with the euthyroid goiter, whether we are dealing with goiter with hypothyroidism or hyperthyroidism or thyrotoxicosis. So that's how we should.
Right. So essentially, in history, we shall try and look at local effects of the goiter on the one hand, and also
Yes.
any systemic features
Systemic
of
effects.
the underlying thyroid dysfunction. Right. And on
Yes,
clinical
yes.
examination, quickly, maybe Dr.
Yeah,
Abhimanyu Basu, as a surgeon, what would you like to examine quickly?
Oh, thank you, sir. The thing is that any enlargement of thyroid gland is called goiter traditionally, but usually we stamp the patient if the lateral part of the thyroid is enlarged more than the thumb size of the patient is called goiter. So this is arbitrary. This is arbitrary. But whenever a goiter came to our surgical OPD, that means swelling of the neck, in front of the neck, we examined thoroughly the neck, especially for the lymph nodes and the softness or hardness or firmness of the nodules and all those things, and asked for the duration and any pain or other symptoms like that. And then we advise some investigations.
Right. And on clinical examination, maybe it's important to
Yes.
identify whether it's a diffuse enlargement or it's a
Or
nodular
not.
enlargement. That will be important. Right. So in the past, I do remember even in the earlier part of my clinical career, children with goiter were sort of children or adolescents with goiter were passed off as having something called puberty goiter, and apparently suggesting that that's a normal event. Dr. Gandhi, would you still think that puberty goiter will require any evaluation, or will just say that child will grow out of this as the child grows up?
No, previously what we used to say puberty goiter is probably the goiter with some other reason. We all know that during puberty there is slight increase in the size of the gland. This is physiologically. But if goiter size is large, probably patient can have chronic autoimmune thyroiditis, which is very common in the iodine sufficient areas. And in iodine deficient areas, we do get iodine deficiency or what we call as colloid goiter also. So that is also common. So currently it is called as adolescent goiter or adolescent colloid goiter, which is a form of basically what we used to call it as puberty goiter. But it is not puberty goiter, it is a colloid goiter. In chronic autoimmune deficiency, chronic autoimmune thyroiditis is the most common cause of goiter even in during puberty. And for that we do anti-thyroid peroxidase antibodies or anti-thyroglobulin antibodies. But in almost 10 to 15% of the patients, we do see that antibodies are negative and still these patients have goiter. So we need to evaluate these patients very carefully for their hypo or hyperfunctioning of the gland.
Right. So before we come to the investigation part, we have a question already in the chat box, Dr. Rajendra. And maybe Dr. Bansali, because you talked about iodized salt. So the question is, what is your take on salt version which are iodine free, like rock salt? So would you like salt now to be iodine free?
Should I?
Would you want
So,
salt to be iodine free?
I think the Shubhankar, the trend which is going now in the country is that people are, because of more fascinating advertisements we are having now, so the more and more people are now going to prefer for a rock salt. And I'll just tell you the rock salt and the sea salt. The rocks, I just tell you that the rock salt is basically available from that is the area from the Pakistan from where it comes. And that salt is rich in a magnesium trisilicate. So it is rich in a more magnesium, but it is iodine free. And the sea salt, which you get from the seashores, where it is iodine is sublimated with that. So it is additionally added to that, and then it is transported to the consumer. So that's a difference between the two. One is sea salt versus the rock salt. So I will never say that, and I will, because the goiter is still prevalent in many areas of the country. Himachal, yes, it has overcome, but I think a lot of areas of Sikkim and the other surrounding areas of northeast, there is a still high prevalence of a goiter because of the iodine deficiency. The previous few years earlier, there was studies from Sikkim and which showed a prevalence of a goiter around 20% in the adolescent population. So iodized salt has to be continued, yes. Where there really indication not to use the iodized salt, particularly those who are severely thyrotoxic. In that scenario, they can be advised to use rock salt. Otherwise, overall, one should also remember that iodine is not only required for a thyroid hormone synthesis, but it has got additional beneficial effects on the even a cellular function of the brain as well as even the reproductive function. So it has so many pleiotropic effects of iodine rather than only for a thyroid hormone synthesis. So iodine salt is must, it should continue. And yes, those where really it is not indicated, means where it is really not required, then those people can use a non-iodized salt.
Right. So we come back to Dr. Abhimanyu Basu. Sorry, I interrupted you. So what would be the investigations that you would like in a patient who comes to you with goiter?
Sir, so firstly, we usually, when we screen the patient for our surgery, this is out of the question, out of the box. So we advise only the TSH only. But in thyroid disease, the patient comes with say, thyroid disease. Even that this TSH level is important, and it actually so sensitive for the increase of T4 or T3. So it is enough to do the only TSH on a first go. If the level is normal or normal, then we'll go for next step, that is the ultrasonography. This is our standard protocol. Or if the TSH is low or high, then we'll have the other tests also, other hormone assays. Because
So,
in our surgery, the ultrasonography is very, very important.
right. So ultrasound scan would be indicated for those with nodular thyroid disease or even for a diffuse goiter.
All thyroid disease, or
Okay.
diffuse and nodular.
Okay. And now one of the very important tests that one does, especially for a thyroid nodule, because one of the questions that patients have in their mind is, am I harboring a cancer? Is it malignant? I mean, that's always at the back of their mind. Ultrasound does help to sort of provide some sort of answer as to the risks of malignancy in a thyroid nodule. But
Yes, sir.
FNAC possibly is somewhat more definitive in this respect. So, can I ask our pathologist in the panel today, Dr. Jyoti Chaudhary, as you briefly tell us about FNAC, because patients quite often tend to say, no, I won't have anything to do with a needle stuck in my neck. So, people are afraid of it. So, is it something to be very afraid of? So, can you briefly describe what's this procedure, whether it's painful?
Good evening, everyone. Basically, the FNAC thyroid is a very common procedure, which we do as an OPD procedure. And the patient will just doesn't have to take any special dietary care or anything. They can just, it's a walk-in procedure, basically. And most of the patients, 90 to 99% of 90 to 99% of the patients will respond to just plain and simple vocal anesthesia. There are some very hyper anxious people for whom we do give a local anesthetic cream like a lidocaine gel. And in children, we definitely use either a lidocaine gel or even local anesthesia. But most of the procedure is done as an OPD procedure.
Can I ask very quickly? Many adults, many people may have got diabetes, heart disease, would be on aspirin. So, is there a need to stop aspirin for this procedure, or can we
No,
just with the okay, yeah, yes.
Actually, no, because this is such a short procedure and we use such a fine needle that in this case it won't be indicated. We can do it with the medication in continuation. So basically, the needles which we use are around 23 to 25 gauge needles. So they're extremely thin. It's only when we get a very calcified nodule that we need to use a thicker needle around 22. We never ever go below that, you know. So in thickness of the core needle biopsy is never done on a thyroid because basically it's a very vascular organ, and the thinner the needle, the easier the tissue yield actually.
Right. And what do you, I mean, how do you interpret the results of FNAC of the thyroid? How soon can one get the result?
Actually, the initial report can go out on the same day or if not on the next day, definitely. Because we will do a immediate assessment of the cellular yield at the guided FNA room itself, where we have a diffquick station, and most hospitals have these things now in place. And we stain the slide with the diffquick, and we look for adequacy of cells, which is around groups of thyroid follicular cells, at least 6 groups of minimum 10 cells each. And if the specimen is adequate, then we make more slides with the aspirate. If not, then we go in again we are allowed up to 2 to 5 passes actually. So usually the cellular yield at one sitting is quite enough to be able to give a report either the same day or the next day.
Can I just go back and ask? So you said about guided FNAC. So does it have to be guided by ultrasound every time, or can you do it blindly?
Yeah, in today's age, I think most FNACs are done guided. Previously, we used to do unguided biopsies, and even now in some more rural centers, I think unguided biopsies are still done. But then the accuracy of the cellular yield from the lesion proper may not be you may not be able to trust that accuracy, because on the ultrasound guidance, you can see vascularity, you can see the characteristics of the nodule, you can see microcalcifications, you can see a whole lot of things which are very important. Neck nodes, if they are present, so many other things can be seen on ultrasound guidance, which helps us to give out a proper diagnosis.
Right. So as a patient, if I had an FNAC, I would like to know whether I've got malignancy. So how is that possible to tell me with certainty from an FNAC whether the nodule has got malignancy or not?
With reasonable certainty, although most thyroid nodules, around 85% or 90% of thyroid nodules are all benign, and we all know that 10 to 15% are maybe non-benign or malignant. So the frequency of getting a malignant aspirate is actually very less, even in a solitary thyroid nodule. But nevertheless, this is a very important investigation which can give us a lot of clues about whether the nodule is benign or malignant. And for that, there has been several Bethesda's system of classification of reporting these thyroid nodules. And the latest one has been released in 2023. So according to the latest one, we can give the classification, divide the classification in 6 groups. The report is released like that. Would you like me to go through the 6 groups, or
maybe quick?
Okay,
quick
very
one.
quick.
Yeah.
Very quickly, then the first one is non-diagnostic. The chances of malignancy in this is around approximately 13%. And the second one is benign. And in this, the chances of malignancy is around 2 to 7%. The third one is atypia of unknown significance. Chances of malignancy increases gradually to 22%. Then the follicular neoplasm, in which it's around 30 to 35%. And then suspicious for malignancy, wherever we give a diagnosis of suspicious for malignancy, we try to give a qualifier, but which is not always possible. But in these cases, when we give a suspicious report, then the chances of malignancy increases to 74. And when we call it outright malignant, even if we have a few cells showing the features, and we don't have adequate number of cells, and we have a few number of cells, even sometimes one group of cells, which is showing you the features of that malignancy, then we can report that as malignant, and the accuracy goes up straight away to 97%. So it's definitely a very important investigation in the repertoire of analyzing a malignant lesion.
Right, but yes, that's true. But at the same time, I mean, my lesson is, even if you give a diagnosis of a benign FNAC, still it carries a small risk of malignancy. I mean, that's something that we should be aware of.
There is a risk of
Right.
malignancy given along with every classification, every point in the classification of the Bethesda system, especially in the latest 2023 one.
We have a few questions in our chat box. Dr. R. Mishra, what are your dietary recommendations in patients with asymptomatic goiter? Dr. Anil Vansali?
Okay, so dietary supplementation or dietary recommendation in an asymptomatic goiter. Okay, so iron 1, selenium 2, protein 3, and iodized salt in optimal doses, something around, because the concentration in our Indian salt is around 20 ppm. The Tata's iodized salt has a 20 ppm. So if someone consumes around 8 to 10 grams of salt per day, then you really have an iodine of 150 microgram a day. So that should be the recommendation for that.
But the salt recommendations overall by WHO are much lower. One shouldn't be consuming so much of
that's
salt.
true. Because the concentration of the iodine per parts per million in country, the Tata salt has got a 20 ppm. So if you take a 20 ppm into account, and then you say daily consumption of a daily recommendation of an iodine intake is 150 microgram, then the recommendation, then it comes around 8 to 10 gram per day. It is definitely higher. So recommendation by, even if you ask for a recommendation for the salt, it's around 5 gram or 5 to 6 gram. So it's certainly higher, but total daily iodine requirement, something around 150 microgram, you require this much of salt.
Right.
So can I add one thing in this?
Yes, Pramod.
Yeah. During cooking also there is some destruction of the iodine which happens in the iodized salt, and that also reduces the iodine intake. So that also helps us to give the sufficient iodine, and it usually iodine intake is not very high or in excess amount.
Right.
I think
So
the practice is that ideally the recommendation is that you should use the iodized salt on table. But the practice in most of the Indian families are that the salt is added during cooking. So the salt percolates into the material and it makes more tastier. So I think that's a practice, but we lose iodine in that way. So ideally, yes, it should be added on a table, but practice is like that. So you may require even more than that, but your total salt consumption will then definitely much more higher. But only one preparation which was available earlier, that was a Captain Cook salt. If you have seen that advertisement, they claim it does not sublimate, one, and secondly, it has got even a concentration of a 25 to 30 ppm. However, it is no more available. So the most commonly available is iodized salt. That's why I told it's a 20 ppm.
Right. So while we are trying to build up the story as to how to clinically examine and then which investigations, we as I promised, we will go to the questions as put by our colleagues. So one question I have got in my chat box, so we are straight away jumping onto that. Dr. Jain asks how to proceed in patients with retrosternal goiter, any risk in surgical approach. So Dr. Abhimanyu Basu.
Yes, sir. So if the patient has a retrosternal goiter, we need a good CT scan or MRI of the neck. Firstly, to see the extent and the involvement of the other adjacent organs.
So now our friend ultrasound will not do. We have to go for.
Right. We usually do ultrasonography scanning for every thyroid enlargement, and then if there is retrosternal involvement, then we have to have a good CT or MRI. Better CT is done because we can interpret ourselves. MRI is somewhat difficult. It is operator dependent, and somewhat we are not actually habituated to see this. So if there is a vital organ not involved, we can straightway approach from the neck, not always have to do this sternotomy and that. And the interesting and the good for the surgeons at that, all the vascular supply comes from the neck, so we don't have to go in the upper mediastinum by sternotomy.
Okay.
Very rarely we have a very large, in a lifetime, 1 or 2 we have done with the help of the cardiothoracic surgeon when the sternotomy is needed. That's the approach.
Right.
In the neck.
Right. So if you have a retrosternal, then of course you need better imaging modalities, and then you go ahead. And as we heard, that it's not that you always need to split the sternum in order to expose that. You can do it from the neck itself. Yes. That's a good news. Right. So what is a So we just mentioned that we have diffuse goiter, we have nodular goiter. So would Dr. Gandhi, for example, try and tell us, is there a medical treatment for a goiter, or is it all to be pushed to Dr. Abhimanyu Basu?
Yeah, usually, basically, the small goiters, we usually just observe these patients if it is associated with hypothyroidism, like chronic autoimmune thyroiditis, which is associated with hypothyroidism. Levothyroxine is the treatment of choice in these patients, and goiter do respond to these in these patients. In patients with thyrotoxicosis or Graves' disease, where we see goiter is there, probably these patients do respond to anti-thyroid drugs like carbimazole, methimazole. These patients do respond. Goiter size may reduce in these patients. Multinodular goiter and single nodules usually do not respond to medical line of therapy, and probably if nodule is sufficient large, this patient needs to be subjected for surgery. Unless goiter is very large, usually we don't refer these patients for surgery, but then small goiters do respond to medical line of therapy. Euthyroid goiter, levothyroxine therapy is not recommended as of now, unless patient has, we monitor these patient and patient has chronic autoimmune thyroiditis. Sometimes these patients do respond, but then currently it is not recommended to be used for euthyroid goiter. Levothyroxine therapy is not recommended to be used for euthyroid goiters.
Dr. Bansali, so for a diffuse goiter, and the patient doesn't want surgery, and again for a nodular goiter, so what are the medical options available? Please unmute yourself. Please unmute yourself.
So one is the functionality of the goiter, as I think Dr. Gandhi talked about that. If the goiter is functional, if it is a hypothyroidism or a chronic autoimmune thyroiditis, they do respond to L-thyroxine. And if they are thyrotoxic, they are Graves, then they do respond to neomercazole. The problem happens usually with a large multinodular goiter, where you really go for a surgery. For a grade 1 to grade 2 or a moderate size goiter, you have multiple options. So one is the thyroxine suppressive therapy. It is effective only in half of the patients, and the goiter size is also reduced by half in half of the patients, but it does not last long. People have also tried a varying doses of a radioactive iodine for treating the euthyroid multinodular goiter, but again the response is not so satisfactory. Then some people have tried even for a nodules, a large nodule in a multinodular goiter, they have tried even RFAs, the radio frequency ablations and laser ablation, but they are not available everywhere. One, they are expensive and they really need expertise. So we can't say that they are not the medical options or the non-surgical options are available. They are available, but still they are. I still feel, and even the ethanol ablation, people have also injected alcohol into the nodule and shown that there was a reduction in size of the nodule. So these are the options, but these are not the curative options. They give a transient decrease in the size of a nodule, and eventually the nodule grows. So options are there, but the options are not optimal.
Right. So then, if you need surgery, Dr. Basu, so what would be the indications for surgery in the case of goiter?
Sir, first thing first is in a benign disease in euthyroid patients, the cosmetic role is the first indication, and second thing is compressive symptoms. So very rarely the benign disease have the compressive symptoms, except the severe case of thyroiditis or the goiter due to thyroiditis. So we do the near total thyroidectomy or total thyroidectomy as needed, or even the hemithyroidectomy is the nodular goiter or the not the diffuse goiter, but the nodular goiter is restricted to the one lobe. But we should be very, very careful in case when we do the procedure, the surgery in benign disease, that we should be much more cautious to save the important nerve and the parathyroid glands, because patient will not accept the complications if in a benign disease or for a cosmetic surgery. So we have to be more careful. So in benign disease, usually in our unit, the senior most surgeons do the surgery, and in malignant disease, the less senior surgeon do the surgery.
So what is the rate of complications that is generally taken as acceptable? The frequency of complications.
Sir, if even the malignant or the benign disease, if the disease is very much extrathyroid, not very much extrathyroidal, or the neck dissection is not needed as in case of malignant disease, it is less than 1% should be your goal. Less than 1% nerve injury, less than 1% parathyroid injury.
Okay, right. And once you're done for a benign disease, let's say for a thyroid nodule, is hemithyroidectomy or lobectomy, is that what's done? Or you did mention subtotal thyroidectomy. For example, let's say someone has come with a large nodule which is benign, but for cosmetic reasons, the surgery is being done. So what surgery would be done?
Sir, if it is limited to the one lobe, then definitely lobectomy. If it is not limited to the single lobe, then we do near total, not such subtotal. Subtotal concept has gone.
Right. Okay. So what would be the chances of recurrence following a surgery? Because a patient would have undergone surgery with spending a lot of money, maybe not in a government institute, but outside, and would expect that this is now I'm cured of my disease. So is that true? Or if the patient has a recurrence of nodule, does he have a scope to say my surgeon didn't treat me properly, that's why I had recurrence?
Sir, usually we do the surgery for the euthyroid patient. The recurrence is very, very rare in our practice. But in case of thyrotoxicosis or toxic multinodular goiter, if we do subtotal or previous subtotal and near total, nowadays we always do the total thyroidectomy if it is a toxic cases. This is our norms, because we have seen previously our teachers, and we have in books also the near total thyroidectomy for even the toxic multinodular goiter, the recurrence chance is there.
Right. So after let's say lobectomy or thyroidectomy, do you refer the patient back to the endocrinologist or the physician, or does the patient remain under your follow-up?
Usually, this type of patient, usually if it is done for the benign disease, usually the follow-up is done by the endocrinologist. But even if the surgeons should follow the first 2 years 6 monthly, and then yearly, and then 5 yearly for the benign disease.
So Dr. Pramod, you had referred the patient for the surgery. The surgery has been done. The patient comes back to you. So do you put that patient on thyroxine to prevent recurrence of the nodule? Of course, Dr. Basu did say that the recurrence chances are very small.
In benign disease, sir.
Yeah,
Yes.
benign.
So usually if patients near total and total thyroidectomy is done, there is no question of recurrence in these patients. For benign nodules where hemithyroidectomy is done, usually recurrence is not known because that part of the gland hemithyroidectomy has already been done. So chances of developing a nodule in the other lobe which is remaining are very less. It's like a separate disease. We can say that there is a recurrence of the nodule because of some other reason. Thyroxine therapy does not prevent the recurrence, and usually we don't put these patients on thyroxine. We just monitor these patients' thyroid functions at regular interval and presence of any goiter. That's all.
I agree, sir, because it is not the recurrence but de novo disease.
Yeah.
Okay, fair enough. Right. So as we started our discussion with that, in relation to goiter, one of the major concerns is whether it's malignant. So can we ask our pathologist as to what does it mean if someone has got a thyroid malignancy? In the sense, someone has got a stomach cancer, pancreatic cancer, and a thyroid cancer. So how does it compare?
I mean, thyroid malignancies are, there are some, the most common thyroid malignancy is the papillary carcinoma of thyroid, which is very, very, very treatable, and surgery is the form of therapy for that. And the results are very good. Prognosis is also very good. And the only prognostic hurdle in such cases would be, accumulation of mutations over time. And that's a separate topic altogether. And the smaller percentage of the malignancies may be a medullary thyroid carcinoma, which is associated with familial other cancers, and or a poorly differentiated carcinoma of thyroid, or a lymphoma of the thyroid, or an anaplastic carcinoma of thyroid. These carry a lot of mutational load, and their prognosis is more guarded. And of course, we have some targeted therapy for PTC as well, which if, in cases of widespread disease, if the BRAF mutation is positive, especially the V600E mutation, then there are targeted therapies for that. But if there is accrued mutations even in these papillary thyroid carcinomas, say for instance a 601E mutation instead of a 600E, then along with a telomerase mutation, then the cases will become more aggressive. Otherwise, and there are many other cancers which can happen in the thyroid from the mesenchyme of the thyroid as well, and metastatic cancer in the thyroid is also seen. These are all very, very rare.
But the vast majority, as you said, of course, is papillary carcinoma.
That's right.
Follicular, both of which generally behave well. So
behave well for surgery.
Yeah, right. Dr. Basu, we come back to you once more. Sorry. There could be some patients who are very fastidious, finicky, maybe from so-called higher strata, would not like to have a scar on the neck, but also need a thyroid surgery. Are there any alternatives, options for them?
Yes. Recently, for the last 5 years, we are doing the minimal access thyroid surgery from a very small scar, not scarless, through the axillary approach. But very recently, by about 2 years or 1.5 years, we have another route to get this really scarless surgery, which is intraoral thyroidectomy. This is also endoscopic procedure. So we give incision inside the mouth and approach from the mouth under the lower lip and goes into the neck, and then do the surgery with 3 instruments. So it is really a scar-less surgery, because in the axillary approach there are 3 small incisions were given, and it is usually till that it is not done for the large malignant thyroid, but yes, small tumor less than 4 centimeter, even malignancy, we can do total thyroidectomy as well.
Would that be your first choice, or a direct thyroid scar over the neck? Is that your first choice?
Sir,
if someone comes with a nodule,
expertise is available and the gland size is small, always go for this thing. And if lymph node dissection is not needed, that's important. This should be the judicious decision. Not only cosmesis is much more important, but the exact operation is done or not. And it is with our little experience, we have seen the chance of nerve injury is less than the open surgery because the visualization is very, very good.
Oh, okay. Okay. So you need special instruments for this.
Yes, not
Or
much special instruments, sir. Not much, very few modification of our normal laparoscopic instrument.
right. So as we sort of come towards the end of our discussion period, once again, if there are more questions, let me check the chat box once again. There's a question, I don't know who would answer. Dr. Verma wants to know, do you directly recommend surgery without trial of levothyroxine in benign, of course he said, diffuse multinodular goiter? I do not know exactly what our friend wants to know. So essentially, would you go for surgery without having the benefit of trial with thyroxine? Is what he wants to know. Dr. Basu?
Oh, so, sir, diffuse multinodular goiter, there is no entity, sorry to say. But in also diffuse goiter, if there is cosmetic indication, you go for surgery. But yes, with to experienced thyroid surgeon because benign disease. Multinodular goiter, definitely, if there is symptoms, if there is cosmetic issue, go for surgery. There is no ways, as clearly Sir Bansali sir has said, there is a very temporary relief of even the radioactive iodine and the thyroxine therapy. So surgery is the only cure.
Right.
I think
So,
Shubhankar, I can add, we had a
yes.
very limited experience with the alcohol ablation. So we had around 15 patients done at PGI when I was there. So yes,
perhaps
so
are
there
also
was a
done.
response. There was a 50% almost reduction in almost 70% of patients, but it did not last long. So I think the all optional medical managements basically they do help for a time being, but they are not the curative. If someone really has got a large multinodular goiter, the best is if the cosmetic issue or compressive symptoms are the issue, the best is go for a surgery rather than trying thyroxine or a radio ablation, which are maybe which may be absolutely ineffective in that way.
Right. Our center also, from our department also, we have had a fair bit of experience of percutaneous ethanol injection.
Yes, sir.
And at least in our study, even solid nodules did show a reasonable degree of response, though by and large it is suggested that only the cysts would respond well. Solid nodules is not an indication for percutaneous ethanol injection. But one of the questions for Dr. Basu, it's suggested that if you have done an ethanol injection, your subsequent surgery may be more difficult, maybe because it causes more sclerosis around the area. Do you think that would be a concern?
Somewhat, because during your study, the many patients are coming for surgery later on, but still it is manageable.
Okay.
I think the alcohol-mediated the coagulation necrosis, which happens after the alcohol injection, is a very transient. So I don't think it produces any hindrance to the surgeon for a later surgery.
Right. So I have been informed that to date there have been 1,100, more than 1,100 doctors from across the country who are following these experts in their fields, and it's heartening to know. And so we would like to have maybe a quick sort of word of advice from each one of our panelists before we wind up.
Before wind up, sir, I have a question to the august panel, because I am the only person who are not endocrinologists. So, sir, I have read somewhere that the biotin containing vitamin supplement hampers the TSH estimation or like that. Do you routinely recommend the patient that don't take the vitamin supplement 2 days before like that?
I think Dr. Abhimanyu,
Yeah.
this was with the biotin assay. The biotin is interfering with the Roche assay. If someone is doing other assays like Emulite and Siemens, then it is not. It is only with the Roche assay where the biotin supplementation is affecting the TSH estimation. So I think one has to take some precaution in that. Suppose you are finding a haywire or a varying TSH values, then you require this suspicion that patient might be on a biotin supplementation and the test has been done by the Roche assay.
Yeah, so once again, to respond directly, so whether we ask every patient to stop biotin or ask about biotin, probably we
Not
won't.
biotin, sir, vitamin supplement.
Yeah, I know.
It is
And these, and these are prescribed very handsomely by dermatologists, especially. But we don't do that. But as Dr. Bansali said, only if we come up with odd values, and it's interesting that the assay that it does, the assay interference that biotin does, can on the one hand cause a falsely low TSH value, and at the same time can cause a falsely high T4 value, giving you absolutely a picture like thyrotoxicosis, overactive thyroid. And on top of that, if we do a TSH receptor antibody, which we do nowadays to supplement to our diagnosis of Graves' disease, that can also be falsely positive. So altogether, we may be absolutely on the false path unless we also clinically examine the patient and decide whether we are on the right track. So short answer is not on a routine basis, but if we have suspicion, then we ask them. So finally, though this was not directly what we wanted to discuss this evening, but Dr. Jain wants to know treatment choice for Graves' disease in lactating lady. Dr. Pramod Gandhi, the difficult question is for you.
No, yes, thank you, sir. Even in lactating ladies, medical management with carbimazole can be given in these patients safely. There is no contraindication for giving carbimazole during pregnancy unless we give it in very high dose, more than 40 to 60 milligram per day. But obviously, radioactive iodine is absolute contraindication during lactation and pregnancy. And if goiter,
yes.
Yeah, I can make a comment. Yeah, Shubhankar, for a lactating mother, the recommendation is that you can use a neomercazole up to 15 milligram. Because the dosage exceeds more than that, then you have enough secretion of the drug into the milk, which is good enough to interfere with the hypothalamo-pituitary thyroid axis of the neonate. So the recommended dosage, if someone is up to 15 milligram, it's fine. And secondly, you can also have a lag time of around 4 hours between the tablet intake and the breastfeeding. So I think that can also be taken care of.
Yes, I mean, that's what is commonly advised, but in practice, you have to realize that breastfeeding isn't just once in a day. Breastfeeding will be several times in a day, so keeping that gap could be challenging. Yeah.
Keep a lag time of 4 hours, so the rest of the time you continue to feed. No issues.
Right. So the final question now is from Dr. Agarwal. What therapy do you continue long-term post-total thyroidectomy? Any nutritional supplements? We do not know exactly what Dr. Agarwal has in mind. Of course, Dr. Bansali, would you like to respond?
I don't think any nutrition
Of course,
supplements required.
no. Yeah, but thyroxine replacement following total thyroidectomy you need to give. If it's
you
for
need to do
malignancy,
replacement,
maybe
thyroid
suppressive
extra
doses.
Yes. No
Right.
thyroid extra supplementation, and even in a suppressive doses, but at least usually these people are usually elderly. So again, we like to keep a TSH around 2 to 3, not the really low suppression, say less than 0.1 like that. So I think one has to take care of this part. So only thyroxine supplementation and keeping the TSH in a age match range.
Sir, calcium
Right,
supplementation
yes.
is a must.
Yes.
No, not.
Calcium supplementation.
No, I mean, calcium in
Calcium
general.
supplementation is only required if you are really going to suppress the TSH below the subnormal range, means in a toxic
No,
range.
I'm
So
talking
below
about
0.1.
sir.
Okay, fine.
So thank you very much. Thank you all the panelists, and of course all our friends from across the country who have shown interest, joined, and put in interesting questions. And of course, also thanks to the sponsor of this session, Intas. And so over now to the organizers for the concluding remarks.
Thank you very much.
Very
Thank
good evening,
you.
doctors. Today again, we had a very important deliberation on the topic of goiter. And I think since we were privileged to host varied specialty during this program, we could divulge into various facets of management of goiter, and that would have cleared a lot of ambiguity or myths which the audience would be having related to this topic. I would like to individually thank Dr. Anil Bansali, Dr. Pramod Gandhi, Dr. Jyoti Chaudhary, and Dr. Abhimanyu Basu for bringing in their valuable insights during this program. We are always deeply indebted to Dr. Shubhankar Chaudhary for him being a backbone of this program. And he has kept the audience completely hooked onto this program. And I'm very, very happy to share. Sir gave an update of 1100. We have crossed 1319 doctors in today's session. So we are very thankful to each one of you for making this program so very interesting, so that the doctors could leverage maximum out of this program. I would like to thank each and every attendees who has been again decided to come back to this program and trying to spend this weekend with us. I hope we could get you a lot of academic insights which will help your practice in times to come. Have a nice weekend going ahead. Thank you, doctors.
Thank you very much.
Thank you very much.
Thank you.
Thank
very much.
you.
Thank you, sir. Thank you, ma'am. Thank you very much.
you.
Thank you, sir. Good night, sir.
Good night, sir.
Good night.
Good night.